Hello and welcome to Desera Clinical Education's Oncology Podcast. I'm your host, Kendall Schick. Today's episode features James Davis, PharmD, BCOP, from the MUSC College of Pharmacy in Charleston, South Carolina, and Kelley L. Julian, PharmD, BCOP, from the Huntsman Cancer Institute in Salt Lake City, Utah. Today, they'll be discussing the optimization of anti-CD38 based treatments for smoldering and newly diagnosed multiple myeloma and related key trials. This episode is part of a larger educational program titled Optimizing Outcomes with Anti-CD38 based treatment for smoldering and newly diagnosed multiple myeloma, best practices for oncology pharmacists. For more information on Drs. Davis and Julian, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
The history of smoldering myeloma dates back to the mid-70s and early 80s, where two physicians from Mayo Clinic, Dr. Kyle and Evan Beck, went back and reviewed 334 cases of what they called multiple myeloma. And they identified 6 patients that actually never progressed to have a symptomatic disease. And so they realized, maybe we shouldn't be calling all of these patients having active myeloma when there were 6 patients that actually didn't have any symptoms. So they termed this expression smoldering multiple myeloma, and that was more recently adopted in 2003 by the International Myeloma Working Group. There have been a number of risk models for the stratification of patients with smoldering myeloma, and those date back to the PETHMA risk stratification model to the most recently the 2020 IMWG model, which takes the Mayo 2018 model, often called the 2220 criteria, and they add cytogenetics or molecular findings to that model. Essentially, the 2-20-20 are numbers, so a serum protein over 2 grams per deciliter, and involved to uninvolved light chain ratio of above 20, and at least 20% of plasma cells in the bone marrow. The refined model added these additional risk factors to show that patients that may have one of these risk factors can be divided into low risk, low intermediate risk, or high risk. So the biggest ongoing debate in the field is, for patients with smoldering myeloma, do we observe them or do we treat them? There have been a number of randomized trials without clear survival benefit leading to this controversy. We've looked at early melphalan, we've looked at bone modifying agents, we've even looked at siltuximab. In all of these trials, although small numbers, none of them have observed an overall survival benefit in one arm or the other. The Kyrodex trial, which looked at observation versus intervention with lenalidomide plus dexamethasone, there appears to be quite a difference in the lenalidomide and dexamethasone group when compared with observation, not only in PFS, but also overall survival. There are important considerations to think about, and this is why it's important to really analyze these trials. The main consideration is this study was conducted before the widespread use of advanced imaging like PET-CTs or MRI scans. And so many patients that were on the observation group may have had active myeloma or myeloma that wasn't found because they weren't doing these scans. This was the first study to show survival benefit. The second study was the ECOG Akron study, which is a study group here in the United States led by Sagar Lodhi at Emory Cancer Institute. And it was published and presented at ASCO about 7 years ago, and it looked at lenalidomide by itself versus observation in smoldering myeloma. The progression-free survival curves, there was also a difference with a hazard ratio of 0.28. However, this trial allowed enrollment for up to 5 years from the diagnosis. The advanced imaging here, the PET-CT scans, were not mandatory. Over half of the patients were missing this cytogenetic FISH data, and they used older stratification criteria to stratify patients into this high risk. So the third trial is the more recent Aquila trial, which randomized patients in an international fashion to either daratumumab or active surveillance for high-risk smoldering myeloma. Daratumumab was given every week for 2 cycles, every other week until cycle 6, and then every 4 weeks for 36 months, so about 3 years versus active monitoring. Primary endpoint here was progression to active myeloma using the slim crab criteria. The investigators re-stratified by use of the more current 2018 Mayo risk stratification and found that only about 37 to 40% of patients actually had high-risk smoldering myeloma by the newer standards. They found the hazard ratio still favored the daratumumab arm. The progression-free survival by an independent review committee found progression-free survival in favor of the daratumumab arm. There was an overall survival benefit that was significantly different, but without proper crossover post-treatment care, the overall survival benefit is difficult to interpret. If we're given a drug, it always has safety concerns. For daratumumab, it's a pretty mild drug, except we often see infection risk. Most commonly, there was more pneumonia and higher grade pneumonia in patients with daratumumab. And so our algorithm for managing smoldering myeloma really focuses on patients with high-risk smoldering myeloma based on that current 2020 IMWG high-risk stratification. We have an option for daratumumab for some patients, and then we have lenalidomide or observation. And there's no really right or wrong answer. It's really dependent on the patient, their age, comorbidities, and mainly their patient preference. All right, so I'm going to introduce Dr. Julian, KJ as I call her. She's going to talk to us about transplant-eligible patients with newly diagnosed myeloma.
Thank you, James. Appreciate that. To scope the problem for treatment of newly diagnosed patients with myeloma, this year alone, we're going to have 36,000 new cases diagnosed here in the United States with over 10,000 deaths. And in 2022, there was an estimated 192,000 people living with this disease in America. We have incrementally improved the 5-year overall survival rate in the last decade, but this is largely a disease of the elderly with the median age of diagnosis at 69 years. And while prognosis has significantly improved with some of these novel agents we're going to talk about, this disease is still largely considered incurable. So let's look at how we're going to move the needle. The stem cell transplant eligible patients, we're going to look at some data through the induction, consolidation, and maintenance phases of treatment, trying to prolong progression-free survival and prevent that first relapse as long as possible. First, let's level set and talk about the 2024 IMWG consensus on defining high-risk myeloma. The main goal of this consensus criteria was to move beyond the R-ISS and the R2-ISS, which many clinicians felt did not accurately capture the most aggressive 20% of cases in the era of quadruplets. By consistently applying these criteria to newly diagnosed patients, clinicians can more readily identify patients who are at risk for early relapse despite our modern treatments, and this allows for more informed discussions regarding treatment and long-term monitoring. Let's talk about the depth of response. You're going to hear me mention, and James mention, MRD, which is minimal residual disease, and this refers to the persistence of residual tumor cells after treatment and is cause of major relapse. Someone was talking with me the other day, and they used the cleared yard analogy. And what that means is, compared to traditional response monitoring, if you're someone looking out of a house window down at a yard and myeloma represents if there's any weeds in the yard, it might look like if you're looking down out of a window that the grass is perfectly clear of weeds. But what that would be kind of representative of a traditional complete remission and what that looks like. But if you got down into the grass with a magnifying glass on your hands and knees and you looked at every single blade of grass, if you looked at 1 million blades of grass and you were MRD negative, then you would not find a single weed there. In the transplant eligible side of things, whether a patient has standard risk or high risk, they're largely going to get a quadruplet, which is an anti-CD38 monoclonal antibody backbone with bortezomib, lenalidomide, and dexamethasone. Both standard and high-risk patients are eligible for quad. Occasionally, we may give a standard risk patient less therapy than that, but that's exceedingly more rare as we get more experience with quad regimens. So we follow that by transplant, and then we'll have a risk-adapted maintenance strategy. Digging into the rationale for why we use anti-CD38 monoclonal antibodies in combination with immune modulators like lenalidomide or pomalidomide, we like to target the cluster of differentiation 38 because we know it's highly expressed on the malignant myeloma cells, and it functions as a receptor, adhesion molecule, and an ectoenzyme mediating immunosuppression, and it is uniquely expressed in the bone marrow microenvironment and immune cells. When we combine it with the immune modulators, there's synergy through various different mechanisms. Starting with the determination trial, this was a phase 3 major landmark study that evaluated the role of early autologous stem cell transplant versus not in the era of modern triplet therapy with continuous maintenance. The most critical takeaway from this determination trial for your clinical practice is that while transplant did offer a massive PFS benefit, 67 months versus 46 months, it did not translate into an overall survival advantage when we have more effective salvage options available. So transplant, still an option. It's a viable option for a lot of patients, but this did open the door for other options to also be kept in mind if you have a patient who maybe isn't good for transplant. Moving to the Griffin and Perseus trials, Griffin was the phase 2 and Perseus was the phase 3 trials that definitively studied and established daratumumab with a combination of bortezomib, lenalidomide, and dexamethasone as the frontline quadruplet induction for these transplant-eligible patients. While Griffin provided the proof of concept and used IV daratumumab, Perseus confirmed these findings in a larger population using the subcutaneous formulation. Moving over to the isatuximab trials, you've got the GMMGHG7 and the ISKIA. What I want to highlight here is that these are the isatuximab trials that really provided the evidence we needed to move these into the frontline setting as well. So the HD7 trial was the premier induction quadruplet for transplant-eligible patients. Similarly to Perseus, which focused on the daratumumab, this trial provided the high-level evidence we needed with isatuximab-based backbones, with the primary endpoint of MRD negativity, which was significant. And the ISKIA trial highlighted the effectiveness of this ISA-KRD quad in high-risk and double-hit myeloma patients. So the MRD negativity rate with the ISA-KRD arm were consistently high across the risk groups. So this trial did demonstrate that this ISA-KRD quad could be considered the gold standard for high-risk, newly diagnosed transplant-eligible myeloma patients. Stopping again to think about the importance of MRD, MRD negative status surpasses the prognostic value of a complete response or complete remission achievement for PFS and OS. So MRD negativity should be considered as one of the most relevant endpoints for transplant-eligible and elderly fit patients with myeloma, because standard complete response is no longer a high enough bar, given that the MRD negative status represents a much deeper clearance of disease. The Perseus trial showed consistent PFS benefit across all of these subgroups, including the small subset of patients in this trial that had high-risk disease. MRD negativity was sustained over time, an odds ratio of 4.4. And the clinical meaning there is that patients in the daratumumab VRD arm were 4 times more likely to achieve and maintain MRD negativity for at least 1 year as compared to those patients in the VRD triplet arm. Again, I want to point out that safety profile was very safe. No unique signals were seen here in the Perseus trial other than the grade 3/4 neutropenia, which was upwards of 60%. This did not lead to an increase in treatment discontinuations. The concept trial really proved that high-risk disease requires high-intensity therapy. So the use of the ISA-KRD heavy quadruplet induction followed by a triplet maintenance of ISA-KR was studied and is currently one of the most effective strategies for closing the survival gap between those high-risk and standard-risk patients. The MIDAS trial was really the first one to demonstrate that a response-adapted therapy is feasible in multiple myeloma. So the standard risk question was answered through Arm A versus Arm B. Everyone received ISA-KRD induction, followed by an MRD evaluation, and those who were MRD negative were randomized to either ISA-KRD for another 6 cycles and lenalidomide maintenance, or a transplant followed by 2 cycles of consolidation and lenalidomide maintenance. In these early responders, Arm A and Arm B comparison on the post-induction side were virtually the same. So this was a non-statistically significant p-value and suggests that for patients who achieve early deep molecular clearance with ISA-KRD induction, adding a transplant does not significantly deepen the response further. In summary, MRD is a valid tool for making real-time clinical decisions in this disease. Upfront transplant may be optional for patients who achieve a deep molecular response. However, potent consolidation can also effectively substitute for more intensive surgical-like approaches, such as tandem transplants in slow responders. Lastly, the Auriga trial demonstrated that adding subcutaneous daratumumab to standard lenalidomide maintenance was significant in the 12-month mark. The MRD negativity conversion rate was 50% versus 18% and showed prolonged progression-free survival compared to lenalidomide alone for myeloma patients who were remaining MRD positive post-transplant. So in summary, for transplant-eligible newly diagnosed patients, we have a uniform definition of high-risk myeloma, which is now in place and moving the needle for treating these patients aggressively. Quad induction is clearly important and drives higher rates and depth of response pre-consolidation. The role of high-dose therapy continues to be important. Risk-adapted maintenance remains an important approach. And the data on early depth of response predicting long-term outcomes does need continued PFS confirmation. And with that, I'll hand it back over to James.
Thank you. Now, my job is to talk about the role of induction treatment or frontline treatment for patients who may be frail or older. And so typically we're not transplanting patients who are frail or above the age of 70, and we're trying to get away from this age, this absolute age. So frontline treatment currently involves induction of a 3 or 4 drug regimen. And in the consolidation phase, we're not doing autologous stem cell transplant as much for these patients. We're moving to more prolonged induction strategies. So you continue the induction from stopping at 4 cycles and going to transplant. You continue that induction for 6 to 8 to sometimes 9 or 12 cycles. Eventually, you move on to a maintenance phase, which is typically giving a 1 or 2 drug maintenance, something like lenalidomide, maybe lenalidomide plus bortezomib, or lenalidomide plus daratumumab, as Kelley described previously. There are some considerations on how to pick and how to evaluate patients that are elderly or frail. And like I said previously, we're essentially just getting away from this age cutoff, and we're incorporating frailty assessments that include performance status, comorbidity index scores, personal preferences, things like that. The MAIA trial is the landmark trial that showed the combination of daratumumab, lenalidomide, and dexamethasone, or DRD, essentially beat the doublet of lenalidomide plus dexamethasone in this older transplant-ineligible population. Not only did the median progression-free survival trump the 2-drug regimen, but also there was an overall survival benefit at 7.5 years of follow-up. The SWOG 0777 trial compared the older regimen of VRD versus RD in this transplant-ineligible or deferred transplant population, and again, showed benefits in regards to progression-free and overall survival. So this really sets the stage for our 3 big quadruplet therapy trials. And these 3 trials are the BENEFIT trial, which was a cooperative group trial we'll cover, the MRAS trial, and the CEPHEUS trial. The BENEFIT trial looked at the quadruplet of ethotuximab plus bortezomib, lenalidomide, and dexamethasone, and it compared that to still an ethotuximab-containing regimen, but also lenalidomide and dexamethasone. They gave that for 12 cycles, and then they dropped the bortezomib after cycle 18. They dropped the dexamethasone as well, and then from cycle 19 onwards, they gave just the ethotuximab and the lenalidomide. And what they found was the MRD negativity rates favored 4 drugs over 3. There were higher rates of MRD negativity at both 12 and 18 months for the 4-drug regimens, and there was about a 5.2% difference in progression-free survival favoring the quadruplet versus the triplet. The primary outcome for this study was looking at MRD. So MRD here was the goal, and that's what they were able to achieve. The MRAS trial was another ethotuximab trial, and instead of isolating the effect of bortezomib, they isolated the effect of ethotuximab. You have the older triplet VRD, which after a number of cycles just continued more of a maintenance of lenalidomide index, and they compare that to VRD plus ethotuximab, eventually here dropping the bortezomib due to the risk of neuropathy. 60-month progression-free survival was almost 20% different, favoring the quadruplet arm. MRD negativity at 10 to the -5 was also favoring the 4-drug regimen over the older standard of the 3-drug regimen. So 4 drugs beats 3 in both of the ethotuximab trials. What about the daratumumab trial, the CEPHEUS trial? This trial is isolating the effect of daratumumab. And so we're looking at daratumumab plus VRD continued for 8 cycles and then on to daratumumab RD maintenance versus the older triplet of VRD, then dropping the bortezomib due to the risk of neuropathy at cycle 9 and continuing lenalidomide and dexamethasone-based maintenance. They're looking at MRD negativity, progression-free survival. And again, 4 drugs beats 3, almost a 20% difference in 54-month progression-free survival in favor of the daratumumab VRD arm. MRD negativity also favored 4 drugs over 3. So all of these trials, there was slightly more adverse effects in the 4 drug arms. Typically, these are infections. Upper respiratory infections are common with these anti-CD38 monoclonal antibodies. And so those are things to watch out for in these patients. Serious infections, MRS 30 versus 19%. Pneumonias, infections 92 versus 86% of the Cepheus trial. The benefit trial is a good one to look at because it did isolate the effect of the bortezomib. And so in the non-bortezomib arm, the ESA-RD arm, there was far less peripheral neuropathy in these patients. And at grade 2 plus peripheral neuropathy is something to watch out for if you have frail patients and older patients, because peripheral neuropathy here happened in almost 30% of these patients versus 10% of patients in those who did not receive bortezomib. So that's something that we have a low threshold to either dose reduce or eliminate that drug if we're giving older, more frail patients bortezomib, if they have baseline diabetes or if they have baseline peripheral neuropathy. Those are things to consider as well. I will be remiss if I didn't mention the current trending movement down with Dex, led by one of my colleagues and friends, Rahul Banerjee at Fred Hutch in Seattle. He and some other brilliant minds published some studies looking at the efficacy of dexamethasone and whether keeping the doses high, as in like 40 milligrams a week, versus lowering the doses and even eliminating dexamethasone at or before cycle 6 changed efficacy in patients that are receiving these regimens. And they found that surprisingly, eliminating dexamethasone after patients achieve response does not limit efficacy going forward. So at my practice, in my center, we get rid of the dexamethasone as soon as we can to help avoid some of these side effects these patients are experiencing. So some important takeaways for these transplant-ineligible patients. We're able to give quads to really most patients unless they're have uncontrolled diabetes or baseline peripheral neuropathy. Most patients are able to tolerate these quads. It is important to assess not only age, but frailty. We don't really know the optimal length of how long the quad is to be given for and when to best look at maintenance. So that I think we're going to find out some more about that in the coming years. And then some really pharmacy provider pearls here at my center, and it's been shown most of these trials gave bortezomib twice a week, and so we at my center always do weekly bortezomib because it's shown equivalent efficacy and less side effects. We typically start the lenalidomide not at 25 milligrams like a lot of these trials did, but at a lower 10 to 15 milligram dose, and then we can always go up if patients do well. And then for patients over 65 or 70, we often start at dexamethasone 20 milligrams and rapidly taper as we see a response or if they have side effects. All right, so I'm going to turn it back over to KJ, and she's going to take us home with pharmacist, supportive care, and the importance of supportive care as it relates to pharmacists taking care of these patients.
Thank you so much, James. Looking at supportive care for frontline therapy specifically, first, I would be remiss if we didn't talk about how we've really improved safety and patient satisfaction through the use of subcutaneous anti-CD38 monoclonal antibodies. And we think about our monoclonals, we think of daratumumab and isatuximab, as we've mentioned, and the biggest side effect that we see largely up front is an infusion or injection site reaction. And so transitioning these patients from IV therapy to a subcutaneous injection really improves quality because of the time saved and the side effect profile. And so the Columba trial was really the landmark trial that got subcutaneous daratumumab approved, and that's on the market. It is widely used throughout the myeloma space. Isatuximab has 3 trials that got their subcutaneous OBI or on-body injector system to market. Important to stop and mention that no matter what, whether you're giving an agent IV or subcutaneous formulation, every patient needs premedications because the risk is still there for an infusion or injection reaction. So thinking about your dexamethasone steroid and your acetaminophen, diphenhydramine, things like that. Occasionally, you give some other medications in there based on institutional standards. But in general, the pre-meds have to stay the same to mitigate the risk of a reaction. For the Araclia, the Zalco, and Isosocot, these studies are looking at different combinations of isatuximab, subcutaneous injection versus the IV. The overall response rates are extremely high, very low rate of infusion reactions, almost non-existent for the isatuximab trials, and the infusion reactions for daratumumab were in the high 30s, low 40s% range. So you're easily cutting that by half or a third or even more than that when you're looking at these subcutaneous injections. And the key takeaway is that these are maintained efficacy, way better safety, and both patient and provider satisfaction was greatly improved across all these trials. So keeping in mind, super important to remember that they all still need pre-medications, and that does not change. But using subcutaneous formulations has really moved the needle for our patients. As far as infection prophylaxis measures, it's important to remember that the monoclonal antibodies and the proteasome inhibitors that we use really put patients at high risk for viral reactivation of HSV and VZV. So these patients should remain on acyclovir or an equivalent drug for the duration of therapy and even for a few months after to mitigate that risk. And if a patient is neutropenic, we're looking at bacterial prophylaxis with levofloxacin. Neutropenia of an ANC of less than 1,000, you would consider growth factor support, which we use liberally at my institution, and I know others do as well. When they are neutropenic, you need to consider prophylaxis with fluconazole to prevent invasive fungal infections. We're following standard antiviral recommendations if a patient was exposed to influenza or COVID-19 and recommending vaccination per institutional recommendations. And then I'd be remiss if I didn't call out hypogammaglobulinemia as marked by an IgG less than 400. We don't see this as often in the induction space, but this is something that the pharmacist plays a huge role in identifying, and we can give those patients IVIG to keep them on therapy and safe. Thrombosis is a huge risk in the myeloma patient population, especially in the first 6 months of therapy. So the pharmacist can here, again, play a huge role in managing DVT and PE risk by adjusting medications and schedules and working through the different scoring systems, which can be found if you search the guidelines and assess the risk. Many patients qualify for DOAC if you're thinking they're at higher risk, especially if they're going to be on IMiDs. Some centers do feel comfortable with aspirin, but either way, the pharmacist can really take point in some of those conversations and balancing the risk versus benefit. We don't normally see super high rates of thrombocytopenia in the induction setting, but it can happen. So again, balancing your medications with the platelets are important to think about there. The symptoms that come around peripheral neuropathy are largely numbness, tingling, prickling sensations, even sensitivity to the touch. We can prevent this, and it is reversible in most cases. So early reporting of these symptoms and intervention are critical to make sure that this is reversible for our patients because we want to treat them for as long as possible. So whether we do neuroprotective supplements, we prescribe an oral or topical pain medication, ensure their environment is safe so they're not a fall risk, or even dose adjust or dose hold.
Thank you, Doctors Davis and Julian, and many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Optimizing Outcomes with Anti-CD38-based Treatment for Smoldering and Newly Diagnosed Multiple Myeloma, Best Practices for Oncology Pharmacists, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.